This is the lecture on suicidal thoughts and behaviors. Suicide or completed suicide is the intentional ending of one's life. Suicide attempts, then, are all willful, self-inflicted, life-threatening attempts that have not led to death. Suicidal ideation is a person thinking of self-harm. Suicidal ideation should always be taken very seriously if the patient mentions any type of suicidal ideation. Always ask patients, are you thinking of harming or killing yourself? Listen very carefully to what he or she does or does not say. Some more definitions. Suicide is understood from different perspectives that include religious, philosophic, sociologic, psychologic, and biologic. Recent growth of secular philosophy affords respect for an individual's will and basic human rights and has influenced the perception of suicide in our society. And this has led to physician-assisted suicide for the terminally ill under strict guidelines. Oregon and Washington State have sanctioned physician-assisted suicide, as well as Netherlands, Belgium, and Switzerland. And we'll talk about physician-assisted suicide in Oregon and Washington in a couple of more slides. Suicide, in its many forms, has inspired everything from condemnation to romanticism, most focusing on the morality of taking one's own life and whether it can be justified as a reasonable option. For example, Romeo and Juliet, it has been romanticized. Most people don't want to die, they just don't know how to live with their prolonged, deep psychic pain. What about a patient whose every moment is suffering intractable pain from a terminal illness and wants to leave life with some dignity? So those are some things to think about in terms of suicide and the psychic pain that these patients are going through. Physician-assisted suicide for the terminally ill was a law that was established in 2009 that legalized it in Washington State and Oregon. The law says that the patient cannot have any neuromedical or psychiatric conditions that impair their capacity to reason or process information. They have to have been diagnosed as having less than 6 months to live. They have to make a request orally and in writing and have the agreement for physician-assisted suicide approved by 2 different physicians. And they have to make the request again after a 15-day waiting period. Suicide is the 8th leading cause of death in adults ages 50 to 64 years. However, the rate seems to have dropped off in patients 65 years and older. This is likely because of the baby boomer cohort has a higher rate of suicide than any other group, and they began reaching the age of 65 just in 2011. 90% of patients who attempt suicide have a diagnosable psychiatric condition. The risk of suicide in patients with major depressive disorder is 20 times higher than the general population. And then there's also alcohol and substance abuse issues. Patients with schizophrenia, dementia, bipolar disorder, generalized anxiety disorder, post-traumatic stress disorder, Parkinson's disease, and other psychiatric disorders also have a higher suicide rate than the general population. 5% of patients who complete suicide have a serious medical condition at the time of suicide. Patients with a terminal and or painful disease such as AIDS, cancer, chronic renal failure, hemodialysis, or chronic renal failure with hemodialysis, head injury, multiple sclerosis, or Parkinson's disease are at an increased risk. Certain medications may contribute to the symptoms of depression, increasing the risk for suicide, including antihypertensives, benzodiazepines, calcium channel blockers, steroids, hormones, and pain medication. Suicide rate has been tracked among Iraq and Afghanistan veterans since 2008. 1 in 5 deaths of young veterans are the result of suicide. And suicide does not account for risky behaviors that resulted in a disproportionate rate of veterans returning to civilian life who die from motorcycle accidents, motor vehicle accidents, or unintentional poisoning. Psychologists speculate that these deaths are most likely related to risky behaviors associated with PTSD. In California, between 2005 and 2008, over 1,000 veteran suicides were reported. That rate is 3 times higher than the number of servicemen killed in Iraq and Afghanistan over the same period. Traumatic brain injury. Traumatic brain injury refers to trauma to the head that affects brain functioning. Between 15 and 23% of returning war veterans have experienced traumatic brain injury. And PTSD, depression, extreme alcoholism, and other disorders are prevalent upon return from deployment. Risk factors for suicide. And there's an increased risk associated with anxiety, insomnia, and substance abuse. People who attempt or complete suicide often have poor critical thinking skills, troubled emotional lives, and a low threshold for emotional pain. A person may experience one or more risk factors, though, and not be suicidal. Risk factors for youth suicide. Children or teenagers who lost a parent to suicide are 3 times more likely to commit suicide. Other risk factors include childhood maltreatment or abuse, problematic family relations, a history of bullying or victimization, family history of suicide, socioeconomic problems, parental psychopathologic problems, peer problems, and legal or discipline problems. The theoretical basis, there is a strong association between suicide and low serotonin levels. In the noradrenergic system, the biologic responses to stress may be a risk factor for suicide as well. In the noradrenergic system, overactivity of the system is associated with severe anxiety, agitation, and high suicidal risk. The hypopituitary adrenal axis is another major stress response system, and it is associated with major depression, and suicide victims often exhibit HPA axis or abnormalities. There have also been identified genetic factors. Suicide clusters develop in some families, resulting in a family history of suicide. Societal factors. No social supports are available to combat negative events and severe stresses, which can increase the risk of suicide. Psychologic factors. Psychotic tendencies result in an increased risk, especially related to command hallucinations. Feelings of hopelessness, helplessness, and worthlessness are evident in suicidal patients. Adolescents and young adults. The strongest risk factors for suicide are between the ages of 14 and 24 years of age, particularly those who struggle with substance abuse, aggression, disruptive behaviors, depression, and social isolation. Other factors: frequent episodes of running away, frequent expressions of rage and problems with their parents, family loss, instability and withdrawal, perception of failure at work, school or social failure, expression of suicidal thoughts when sad or bored, difficulty dealing with sexual orientation, and an unplanned pregnancy. In older adults, risk factors include social isolation, solitary living, widowhood, lack of financial resources, poor health, and hopelessness. Most older adults who commit suicide have visited with their primary care physician the month before the suicide, sometimes the very day that they commit suicide. Recognition and treatment of depression in the medical setting helps prevent suicide in the older adult. Page 452 in your book, box 23-1, shows an evaluation, the SAD person scale. It's the modified SAD person scale, which is an acronym that can help us to recall when in the midst of a crisis situation. It is helps to evaluate the urgency of the need for referrals to mental health sources or protective caseworkers. So you score it by S stands for sex. If they're male, they get 1 point. A is age, so between 19 and 45, they get 1 point. D is for depression or hopelessness, and that scores 2 points. P, previous suicidal attempt or psychiatric care, is 1 point. E, excessive alcohol use or drugs, is 1 point. Rational thinking, loss of rational thinking, psychotic or organic illness, is 2 points. S, separated, widowed, or divorced, is 1 point. O is for organized plan or serious attempt, it gets 2 points. N is no social support, is 1 point. Stated future intent, determined to repeat or ambivalent, is 1 point. Guidelines for clinical action. So in other words, after you score this, if they're 0 to 5, they may be safe for discharge, but of course that is determined on an individual basis. A score of 6 to 8 probably requires psychiatric consultation, and then over 8 probably requires hospital admission, whether it be voluntary or involuntary. Verbal cues, so indications that the patient is considering suicide. Always take a suicide threat seriously. So an overt statement may be, I can't take it anymore. Life isn't worth living anymore. I wish I were dead. Everyone would be better off if I died. And living is useless. So those are overt, obvious suicide cues. Some covert or more vague suicide cues would be on the other side of the slide. It's okay now. Everything will be fine. It won't be a problem much longer. Nothing feels good and never will again. Or I want to give my body to medical science. Some behavioral cues. Some behavioral changes, such as a patient gives away their prized possessions. They may begin writing farewell notes to their friends and family. They may make out a will, put their personal affairs in order. They may experience global insomnia or exhibit sudden or unexpected improvement in their mood after being depressed and withdrawn, and neglect their personal hygiene. The evaluation of a plan is extremely important in determining the degree of suicide risk. We need to know how detailed is the plan and how lethal is the proposed method. So the highly lethal methods would be guns, hanging, carbon monoxide, or staging a car crash. A lower risk or lower lethality would be slashing the wrists, inhaling natural gas, or ingesting pills. So think about also how available is the proposed method in carrying out the plan. So for example, does the person own a gun, or do they have a gun in their home? So nursing diagnosis. Risk for suicide is immediately important. Self-restraint from suicide is the hoped-for outcome. Other diagnoses may include ineffective coping, hopelessness, social isolation, spiritual distress, chronic low self-esteem, disturbed thought processes, and post-trauma syndrome. Assessment guidelines for suicide risk. If you feel concerned about your patient, trust your gut and always ask, are you thinking of harming or killing yourself? Assess the precipitating event. So is there something difficult you're facing? What's going on in your life? What's happening? And then assess for protective factors as well. Find out if there's a history of suicide in family or friends. Also try to determine the degree of hopelessness, helplessness, and the lethality of the plan. If a history of suicide attempt exists, assess the intent. Is discoverability a high probability? In other words, is there a high probability that the patient will be discovered? Lethality, was a method used highly or less lethal? Injury, did the patient suffer physical harm? Were they admitted to the ICU? Determine whether the patient's age, medical condition, or psychiatric diagnoses place the patient at a higher risk. Certain red flags include suddenly going from sad and depressed to happy and peaceful. Often the decision to commit suicide gives a feeling of relief and calmness. If the patient gives away their treasured possessions. If the patient is to be managed on an outpatient basis, it's very important to determine what their social supports are. Do they have someone who can check on them, someone that they can talk to, someone that that can keep them grounded and continue with their plan of not harming themselves. Also assess the significant other's knowledge of signs of potential suicidal ideation. And then make sure that we give these patients and their families the contact information for community crisis resources. Outcomes. Short-term outcomes. A family member or friend will stay with the suicidal patient overnight. If they are at a high risk, they may be admitted to the hospital with one-on-one suicide watch. A follow-up appointment with a counselor or therapist needs to be scheduled, not just a referral and give them the number to call. It needs to be scheduled for them. They need to be given telephone numbers of self-help groups, hotlines, organizations, and therapists. Long-term outcomes include optimizing the events and environmental factors to help minimize self-destructive acts. Ensure that suicidal individuals will be able to explore alternatives and increase their coping skills and problem-solving skills. State that the feelings of isolation and loneliness are less, and engage in treatment for co-occurring mental health issues. During the crisis period, Table 23-1 on page 455 talks about interventions during the crisis period. You should always follow your institutional protocol for suicidal precautions. Keep accurate and thorough records of the patient's behavior, both physical and verbal behaviors or communication. Put on either suicide precaution, which is one-on-one monitoring at arm's length away, or suicide observation, which is 15-minute visual checks. Construct a verbal or written no suicide contract, and encourage the patient to talk about his or her feelings and alternatives. After the immediate crisis, this is on table 23-2 on page 454. Arrange to have the patient stay with family, friends, or in the hospital if the patient is highly suicidal. Remove weapons and pills and activate social supports. Encourage the patient to talk freely and discuss alternatives to avoid decisions. And contact family members and arrange for crisis. Anti-anxiety and antidepressant medications, if they are needed, should only be given in 1 to 3 day supply to avoid the potential for overdose, and then the patient will need to come back for further prescriptions. Okay, communication guidelines for the suicidal patient. If you look on page 455, applying the art, it goes through a scenario of a suicidal patient interacting with a student, and these are good because they model how you can have therapeutic communication with these patients. So it's important that we encourage patients and explain to them that the crisis is temporary, that they can get through this, that they just need some support. They need to understand and be reassured that their unbearable psychic or physical pain can be survived, that help is available, and they are not alone. A lot of times patients just need that reassurance that they're not alone, and that this too shall pass. So that is the lecture on suicide, suicidal thoughts and behaviors. If you have any questions, you can contact me either through phone or email.